In our previous video we have seen that breathing systems are classified as those with carbon dioxide absorber and those without the absorber. Mapleson systems are breathing systems without carbon dioxide absorption. It is bidirectional system where the flow of gas occurs one way, that is, the inspired and the expired gas flows through the same tube. This leads to mixing of the fresh gas and the expired gas. Contrary to the Mapleson system, the circle system is a unidirectional system where the inspired and the expired gas has its own passage or the tube. Mapleson circuits are three-way T-tube connected to the fresh gas outlet, a breathing bag and a reservoir tube. The other end of the tube is connected to the patient and a spring-loaded expiratory valve. The diagram here shows the arrangement for Mapleson A, but there are other ways of arranging the components of the circuit. This diagram shows other Mapleson circuit. We can note the different positions in which the reservoir bag is placed. Bidirectional systems which Mapleson falls under is classified as afferent reservoir system and efferent reservoir system. This is based on the placement of the reservoir bag in the circuit. Afferent limb is that part of the breathing system which delivers the fresh gas from the machine to the patient. Efferent limb is that part of the breathing system which carries the expired gas from the patient and vents it to the atmosphere through the expiratory valve. If the reservoir is placed in the afferent limb as in Mapleson A, B and C, they are called afferent reservoir systems. If the reservoir is placed in efferent limb as in Mapleson D, E, F, they are called efferent reservoir systems. Hence, the position of the reservoir bags is the sole criteria which helps us identify different Mapleson systems and how they are functionally different. In 1954, an English physicist, Dr. William Mapleson, analyzed the bidirectional flow systems and made some basic assumptions which are of historical interest. The first assumption was that the gases move en bloc, that is, they maintain their identity as fresh gas, dead space gas and alveolar gas. Secondly, the reservoir bags continue to fill up, without offering any resistance till it is full. Third, the expiratory valve opens as soon as the reservoir bag is full and the pressure inside the system goes above the atmospheric pressure. Finally, the valve remains open throughout the expiratory phase without offering any resistance to gas flow and closes at the start of next inspiration. Throughout the video we will use these postulates to analyze each Mapleson system. The first assumption of Mapleson's postulate states that the gases move en bloc, that is, they maintain their identity as fresh gas, dead space gas and alveolar gas. So it is important to know what those entities are. Fresh gas is the gas that we provide to the patient from the anesthesia machine or the gas source. It can entirely contain oxygen but can have other gases like nitrous oxide, air and anesthetic agents mixed with it. When this happens, the concentration of oxygen in it is reduced. During the first part of the expiratory cycle, there is limited carbon dioxide because the gas comes from the upper respiratory tract where limited gas exchange has occurred, corresponding to anatomical dead space. Anatomic dead space is the volume of the lung that does not exchange gas. This includes the nose, pharynx, trachea, and bronchi. This is about 2 milliliters per kg in the spontaneously breathing individual. In the later part of the expiration, carbon dioxide concentration rises corresponding to exhalation of alveolar gas where carbon dioxide and oxygen exchange occurs. Even so, some of the alveolar regions are not perfused, leading to alveolar dead space. Total dead space is the physiological dead space, which is the anatomic and alveolar dead space together. The volume of gas inspired and expired with each respiratory cycle is the tidal volume, which normalized per kilogram is about 6 to 10 milliliters per kg. The total volume in the respiratory cycle per minute is the minute volume. Different system require different minute volume to stop rebreathing of exhaled gas. The requirement also differs whether the system is used in spontaneously breathing patient or mechanically ventilated patient. The term rebreathing refers to a condition in which some of the expired alveolar gas containing carbon dioxide is inspired in the next tidal volume. Different systems have different configurations which determine the amount of rebreathing. Factors that determine the extent of rebreathing are as follows. You can work out how these factors affects rebreathing as the series goes on. The Mapleson A system was designed by Sir Ivan McGill in the 1930s. Known also as the McGill system, Mapleson A is good for spontaneous breathing patients. The schematic diagram of Mapleson A is given here. Note the three-way T-tube connected to the fresh gas outlet, a reservoir bag and a corrugated tube. The other end of the reservoir tube is connected to the patient and a spring-loaded APL valve. The reservoir bag is at the machine end or the source of fresh gas flow. The APL valve is at the patient end. Functionally, the system behaves differently depending on whether the patient is being spontaneously ventilated or is being managed by controlled ventilation. Initially, when the patient inspires, the fresh gas from the machine and the reservoir bag flows to the patient. During expiration, the fresh gas continues to flow into the system and fill the reservoir bag. The expired gas, consisting of dead space gas and alveolar gas, collects inside the corrugated tube and pushes the fresh gas from the corrugated tube into the reservoir bag. As soon as the reservoir bag is full during the expiratory pause, due to the increased pressure from expired gas and fresh gas flow, the APL valve opens. Then, the alveolar gas is vented into the atmosphere through the opened valve. At the start of the next inspiration, the circuit is filled with only fresh gas and dead space gas if fresh gas flow is equal to the minute ventilation. Then, with the initiation of inspiration, system pressure reduces, APL closes, and the cycle repeats. Mapleson A is the circuit of choice for spontaneous respiration, because there is negligible rebreathing. The system functions at maximum efficiency, when the fresh gas flow equals the minute ventilation and the dead space gas which has not taken part in gas exchange is allowed to be rebreathed and utilized for minute ventilation. Flow of fresh gas required is 70 to 85 milliliter per kg per minute, that is approximately 5 to 6 liters per minute fresh gas flow for an average adult. If the fresh gas flow is higher than the minute ventilation, the dead space gas is also vented out. At minute ventilation, dead space gas will be retained in the system. At a flow lesser than the minute ventilation, alveolar gas will be retained and hypoxic rebreathing occurs. To facilitate controlled ventilation, the expiratory valve has to be partly closed to provide positive pressure within the system. During inspiration, when the reservoir bag is squeezed, the patient gets ventilated with fresh gas and part of the fresh gas is vented out through the valve after sufficient pressure has developed to open the valve. During expiration, the fresh gas from the machine flows into the reservoir bag and all the expired gas, that is, dead space gas and alveolar gas, flows back into the corrugated tube till the system is full. During the next inspiration, the alveolar gas in the tubing flows to the patient. This is followed by the inspiration of fresh gas. When sufficient pressure is developed by squeezing the bag, part of the expired gas and part of the fresh gas escape through the valve. The controlled ventilation leads to considerable rebreathing, as well as excessive waste of fresh gas. The composition of the inspired gas mixture depends on the respiratory pattern. The system becomes more efficient as the expiratory phase is prolonged. However, it should not be used for controlled ventilation unless EtCO2 is monitored. The lax system functions like the Mapleson A system, both during spontaneous and controlled ventilation. The only difference is that the expired gas, instead of getting vented through the valve via the patient, is carried by an efferent tube placed coaxially and vented through the valve placed near the machine end. This facilitates easy scavenging of expired gas. In common with other coaxial systems, if the inner tube becomes disconnected or breaks, the entire reservoir tube becomes dead space. This can be avoided by use of the parallel LAC system, in which the inner and outer tubes are replaced by conventional breathing tubing and a Y-piece. Now that we have learned a lot about the Mapleson A system, it's easy to discern its advantages and disadvantages. Mapleson A is tested for leaks by occluding the patient end, closing the APL valve, and pressurizing the system. If there is no leak, the reservoir bag will inflate. APL valve functioning should be checked by opening and closing it. Opening the APL valve will cause reservoir bag to deflate. The LAC system requires additional testing to confirm the integrity of the inner tube. This is accomplished by attaching a tracheal tube to the inner tubing at the patient end. Blowing down the tube with the APL valve closed will cause the movement of the bag if there is leak between the two tubes. Mapleson B and C are similar in construction, with the fresh gas flow entry located at the patient end of the circuit, distal to the expiratory or APL valve, except that corrugated tubing is omitted in Mapleson C as shown in the diagram. This was done in order to reduce rebreathing of alveolar gas by shifting the fresh gas entry to near the patient. They are not commonly used in anesthetic practice because high flow of gases is needed to prevent rebreathing of CO2. Fresh gas flow required is equal to peak inspiratory flow rate, that is, about 20 to 25 liters per minute to prevent rebreathing. So, there is a lot of wastage of gas. The functioning of Mapleson B is straightforward. Since the FGF inlet is near the patient end, during expiration, first part of expired gas, that is, dead space gas and alveolar gas, passes down the corrugated tubing, along with FGF. The tubing near patient end contains FGF and some alveolar gas containing carbon dioxide. As the valve is in patient end, a mixture of alveolar and fresh gas passes out via the APL valve with the increase in pressure inside the system. Then, during inspiration, a mixture of fresh gas and retained alveolar gas is breathed in. As mentioned earlier, they are unsuitable for both spontaneous and controlled ventilation. These circuits requires FGF twice to thrice of minute volume to adequately flush alveolar gas within the circuit and prevent rebreathing. Mapleson D is an efferent reservoir system where the reservoir bag is placed on the efferent limb, that is, expiratory part of the tube or away from fresh gas flow. Same configuration is seen in E and F. Mapleson D is the most efficient system during controlled ventilation. Classic form of Mapleson D has a 6 mm tube that supplies the fresh gas from the machine. It connects to the T-piece at the patient end and the other limb of the T is attached to a wide-bore corrugated tube to which the reservoir bag is attached. The expiratory valve is positioned near the bag. The modified version of Mapleson D called Bain's circuit is the one used clinically. Bain's system was introduced by Bain and Sporle in 1972. In this circuit the fresh gas supply tube runs coaxially inside the corrugated tubing. The diameter of the outer tubing is 22 mm and the inner tube is 7 mm, length of the circuit is 1.8 meter. Outer tube is transparent so that the inner tube can be seen for any disconnection or kinking. Length of the circuit can be increased to modify it for use at remote locations. It also prevents cluttering of fresh gas entry point at the patient end like in classic Mapleson D. During spontaneous respiration, APL valve is fully opened. The patient inspires fresh gas from the circuit and excess gases are vented out through the APL valve during expiration. In controlled ventilation, the APL valve is kept partially closed and the patient is ventilated by squeezing the reservoir bag. Here excess gases are vented out during inspiration. So, during spontaneous ventilation, the gas is vented out during expiration and during controlled ventilation, the gas is vented during inspiration. We will look into the in-depth analysis of this circuit next. When the patient inspires during spontaneous respiration, the whole circuit is filled with only the fresh gas. This gas flows into the patient on inspiration. During expiration, the expired gas gets continuously mixed with the fresh gas and flows back into the corrugated tube and the reservoir bag. When the bag is full, the APL valve opens and excess gas is vented to the atmosphere through this valve. After the expiration, the fresh gas continues to flow and fills the proximal portion of the corrugated tube. During the next inspiration, the patient breathes fresh gas from the inner tube as well as the mixed gas from the proximal portion of the corrugated tube. Many factors influence the composition of the inspired mixture. They are fresh gas flow rate, respiratory rate, expiratory pause, and tidal volume. If the fresh gas flow is high, that is, 1.5 to 2 times minute volume, patient will inhale only fresh gas from the corrugated tubing, and if the fresh gas flow is less than 1.5 times minute volume, some expired gas containing CO2 will be inhaled along with the fresh gas causing rise in end-tidal CO2. Fresh gas flow should be at least 1.5 to 2 times the patient's minute ventilation in order to minimize rebreathing to acceptable levels. Based on body weight, recommendations for fresh gas flow are 150 to 200 milliliters per kg per minute to prevent rebreathing during spontaneous respiration. To facilitate intermittent positive pressure ventilation or controlled ventilation, the expiratory valve has to be partly closed. Upon squeezing the reservoir bag, the fresh gas from the corrugated tube flows into the patient. The pressure in the system also increases, which open the APL valve and the contents of the reservoir bag are discharged into the atmosphere. During expiration, the expired gas flows down the corrugated tubing. It gets mixed with the fresh gas that is continuously flowing into the tubing. During the expiratory pause, the fresh gas continues to enter the tubing and pushes the mixed gas toward the reservoir bag. During the next inspiration, as the bag is squeezed to ventilate, pressure in the system increases, the expiratory valve opens and the contents of the reservoir bag are discharged into the atmosphere. It contains dead space gas, some of the alveolar gas, and fresh gas. The patient gets ventilated with the fresh gas and gas in the corrugated tube, that is, a mixture of fresh gas and alveolar gas depending upon the fresh gas flow. Rebreathing can be avoided by keeping the fresh gas flow high, that is, 1.5 to 2 times minute ventilation, or by increasing the expiratory pause so that fresh gas can push exhaled gases down the tubing toward the reservoir bag to be vented out. Other factors that influence the composition of gas mixture with which the patient gets ventilated are the same as for spontaneous respiration, namely respiratory rate and tidal volume. The good thing about controlled ventilation is that these parameters can be controlled by the anesthesiologist to maintain normocarbia even with rebreathing. Fresh gas flow recommended is 70 to 100 milliliters per kg per minute with tidal volume of 10 milliliters per kg and frequency between 12 and 14 per minute. These are the good and bad about the Baines circuit. It becomes important that the users know how to assemble the parts and ensure its proper function. It's common in exams where students are asked to assemble the Baines circuit. The main part of the circuit is the coaxial tube containing the corrugated tube and the inner fresh gas tube. This tube has two ends, one for fresh gas inner tube and APL valve, and the other end for the patient. The one end of the APL fits into the main tube and other end accepts the reservoir bag. The patient end is connected to the ET tube. We just have to remember to put all the parts on one end, and keep the other part empty for the patient. The pre-use check for Baines circuit involves checking the structural and the functional integrity of the inner tube, outer tube, reservoir bag and the APL valve. In this regard, there are 4 important examinations to be carried out, namely, physical examination, inner tube occlusion test and oxygen flush test for inner tube, and positive pressure test for outer tube and APL valve. The physical test involves checking breakage, kinks, and disconnection of the parts of the system. The positive pressure test checks the integrity of the APL valve and outer tube. It is done by occluding the patient end, closing the APL valve and pressurizing the system which fills the reservoir bag. This means that the outer tube is not leaking. The APL valve is then opened. The bag should deflate easily if the valve is working properly. Outer tube integrity should also be checked by following the simplest innovative method. The operator wets the hands with spirit and the air is blown through the tube. Leak will produce chillness in the hands. Also known as bobbin dip test or Foulkes-Crampton-Smith test, inner tube occlusion test establishes the integrity of the inner tubing. The test is performed by setting a low flow on the oxygen flow meter, and occluding the inner tube with a finger or with a barrel of a small syringe at the patient end. The position of the bobbin will be indicated on the flow meter. Since the inner tube is occluded, there is an increased pressure inside the inner tube. This forces the bobbin to dip in the flow meter due to back pressure if the inner tube is not broken and connected correctly. In oxygen flush or Pethix test, the circuit is first connected to the gas outlet port, APL valve is closed and the reservoir bag is filled partially just like in positive pressure test by occluding the patient end. The patient end is then released whereby we can still find the reservoir bag partially filled. The oxygen flush is activated after that. Due to the Venturi effect, the high flow from the inner tube at the patient end will create a negative pressure in the outer exhalation tubing, and this will suck gas from the bag and the bag will deflate. If the inner tube is not intact, this maneuver will cause the bag to inflate slightly. Mapleson E, also known as Ayer's T-piece, was invented by Philip Ayer in 1937. This consists of a light metal tube 1 cm in diameter, 5 cm in length with a side arm. It consists of 3 parts: inlet, outlet and side tube. Fresh gas enters the system through the side arm, the expired gas is vented through the outlet into the atmosphere and the patient breathes in through the other end of the inlet. Mapleson E system is derived from Ayer's T-piece configuration by adding tubing to the expiratory part of the circuit that acts as a fresh gas reservoir during inspiration. Its capacity should be more than the expected tidal volume. It was mainly used in neonates and infants in whom the expiratory valve would produce significant resistance. However, its use has decreased in anesthesia because it is difficult to scavenge excess gases and high fresh gas flows, that is, 2 to 3 times minute ventilation. For spontaneous ventilation, the expiratory limb is open to the atmosphere. Controlled ventilation can be performed by intermittently occluding the expiratory limb and allowing the fresh gas to inflate the lungs. Since the peak inspiratory flow rates are higher than fresh gas flow, gases are drawn from the reservoir limb during the inspiration. If the reservoir limb capacity is less than the tidal volume of the patient, then air dilution occurs by dragging in the atmospheric air. In such case, the semi-closed system of Mapleson E becomes semi-open system. Breathing system classification was discussed earlier. During expiration, both exhaled and fresh gas pass into the reservoir limb and then to the atmosphere. During end expiratory pause, fresh gas continues to fill the reservoir tube and flushes out exhaled gases. The fresh gas collected in the reservoir limb is then inspired on next inspiration. If the reservoir limb capacity is more than the tidal volume of the patient and fresh gas flow is less, rebreathing can occur. There are 2 important factors to consider while using this circuit. The first one is that the diameter of the reservoir must be sufficient enough to have the lowest possible resistance. Second, volume of the reservoir limb or tube should not be less than the patient's tidal volume. If the reservoir volume is equal to tidal volume, the fresh gas flow should be equal to 2.5 times minute ventilation to prevent air dilution. If reservoir volume is less than tidal volume, the fresh gas flow has to be increased further, otherwise air dilution can occur. If reservoir volume is 0 or there is no expiratory limb, the fresh gas flow should be at least equal to the patient's peak inspiratory flow rate to prevent air dilution. The working analysis of Mapleson E during controlled ventilation is the same as during spontaneous breathing. It is done by intermittently occluding the reservoir limb by thumb, which allows us to have control over rebreathing and air dilution. During inspiration, as the expiratory or reservoir tube is occluded by the thumb, the pressure in the system rises due to the fresh gas flow. This pressure forces the gas into the patient's lung. During expiration, the occlusion is released whereby the expired gas from the patient as well as the fresh gas fills the reservoir tube and are vented out. During the expiratory pause, the fresh gas continues to fill the reservoir tube which is inspired during the next respiratory cycle. Mapleson E provides a low-resistance flow during controlled breathing owing to the large reservoir tube along with the absence of the APL or expiratory tube. The system also has low dead space as the fresh gas inlet is located near the patient end. However, there is significant risk of barotrauma, and since there is no reservoir bag, the pressure reduction effect is not there. The operator doesn't feel the bag during ventilation. It is also difficult to scavenge the waste gas. Mapleson F is a modification of Mapleson E by Jackson-Rees and is known as Jackson-Rees circuit. It has a 500 ml bag attached to the expiratory limb. This bag helps in respiratory monitoring or assisting the respiration. A hole in the tail can be occluded by a finger to direct gas flow to the patient's lungs and provide pressure in controlled ventilation. It also helps in venting out excess gases. The elasticity of the bag provides a pressure buffering effect and prevents barotrauma, a problem often seen in Mapleson E due to overinflation. The bags with valves are also available. It is used in neonates, infants, and pediatric patients less than 20 kilograms in weight or less than 5 years of age. Functional movement of alveolar, dead space and fresh gas during spontaneous and controlled ventilation is same as in Mapleson E system. The relief mechanism of the bag is left fully open during spontaneous ventilation. For controlled respiration, the hole in the bag can be occluded by the user during inspiration, and ventilation is done by squeezing the bag. The flows required to prevent rebreathing are 2.5 to 3 times minute volume during spontaneous ventilation and 1.5 to 2 times the minute volume during controlled ventilation. In this system, during expiration, fresh gas and exhaled gas will collect and mix in the tube and the reservoir bag. During expiratory pause, the expired gases in the expiratory limb are replaced by fresh gas. The next inspiration results in patients inhaling fresh gas both directly from the fresh gas inlet and from the expiratory tube of the circuit as in Mapleson E. Mapleson F offers some advantages as follows. These advantages are also offered by the Mapleson E system. The system is easier to assemble, thereby leading to less risk of malfunction and disconnections. It offers lower resistance to the system as there are no valves involved. The reservoir bag also helps buffer the pressure buildup or helps prevent barotrauma, which is why it is preferred over Mapleson E system. The first disadvantage of Mapleson F, alike all other Mapleson systems, is the requirement of high fresh gas flows. Humidification of gases does not occur as in coaxial circuits like Mapleson F, as rebreathing of humidified expired gas from patients is not allowed. And lastly, there is theater pollution as it is difficult to scavenge the waste gas. Mapleson systems, which are bidirectional systems, are classified as afferent reservoir system and efferent reservoir system based on the placement of the reservoir bag in the circuit. Afferent limb is that part of the breathing system which delivers the fresh gas from the machine to the patient. Effort limb is that part of the breathing system which carries the expired gas from the patient and vents it to the atmosphere through the expiratory valve. If the reservoir is placed in the afferent limb as in Mapleson A, B and C, they are called afferent reservoir systems. If the reservoir is placed in efferent limb as in Mapleson D, E, F, they are called efferent reservoir systems. The summary of characteristics of the 6 Mapleson system are laid down here. This table shows the fresh gas flow requirement for each Mapleson circuit. Mapleson A is best for spontaneous ventilation. Mapleson D or Baines circuit is best for controlled ventilation. Mapleson B is obsolete and C is rarely used today for emergency resuscitation. It is replaced by an ambu bag. Mapleson D, E, and F require higher fresh gas flow to prevent rebreathing. They are next in order of preference list for spontaneous respiration. But they are better than Mapleson A for controlled ventilation. Though individual Mapleson circuits have their own advantages and disadvantages relative to each other, the Mapleson system as a whole has certain benefits and drawbacks compared to other circuits like circle systems. These are laid down here.